Great. Thank you, Dr. Mansouri. So our next speaker for today's session is Dr. Ishit Chauhan, who recently finished as a PGY2 at in general surgery prelim from University of Miami. He did his medical school in China and then decided to take the steps with an intention of matching into general surgery. Currently, he's serving the J1 home country return rule with future plans for continuing surgical training in the US. Outside of surgery, he's an avid fan of football, soccer, and other languages, and culture. Welcome, Dr. Chauhan.
So should I just made you the co-host? You should be able to unmute yourselves.
Alrighty, thank you. Thank you for that introduction. And I hope, let's start. All right, so I had actually requested someone to help me out and actually share a little video of which was kind of like the crux of my past 2 years of general surgery. Isha?
Just a second, she's gonna share it. So sorry.
Or we can just let it be. I'm okay with that as well.
It's there now. It's there. We're so sorry.
Hello, everyone. I'm so sorry. I wasn't made the co-host. So I would like to share a small video that Dr. Ishit requested us to share. This one.
All right, so thank you, Isha. All right, so the reason why I asked for this video to be shared was because it does represent as to what my past 2 years of general surgery have been like. There are many questions that I get as to, oh, what's general surgery prelim? How's it different from general surgery categorical? Blah blah blah. Can you do it for first year? Can you do it for second year? Stuff like that. The main and the most important thing that you have to realize is that once you set your target, once you know as to what you want to do, there's multiple ways of getting there. You will, in my experience, and other people will testify to it, and I'm sure other people already have that have spoken today, spoken about as to how you could have various drawbacks, setbacks. Maybe your application isn't strong enough. Maybe you don't have the adequate, I don't know, the scores, the letter of recommendations aren't up to the mark, or you haven't done enough electives. You don't have enough publications. There will be multiple setbacks during your entire journey. This journey will break you down. And the fact of the matter is, despite that, if you are persistent, if you are stubborn enough, and I know Anudeep mentioned something, if you're stupid enough to dream, and if you're stubborn enough to pursue it, you will get there. There are multiple things in my journey that have been straight up red flags. Many people told me not to pursue surgery. Many people told me, well, firstly, many people also told me not to go to the US. But here we are. So When I talk about my journey, I'll start off from right at the beginning before even going to med school. But before that, I also want to mention that what do you guys think are the various red flags in your applications as of right now amongst the people that are already on the call? I think we have around I don't know, 80 people, 102 people. Cool. So what are the various red flags that you guys think are there on your application? Visa. All right, cool. Visa is a huge one. No surgery oriented research, USCE. Anything else? That's it. Those are pretty easily addressed. Gap. All right. Let's see. So gap of 3 years. All right. No surgical experience, less work, failed attempt, no research experience at all. 2 years out of graduation. Lack of mentors. Not practicing, no one to vouch for. Parents asking not to go to the US. That's fair points. So now I'll start off with my journey, and my journey has multiple red flags. I feel that my journey is an ideal blueprint of what not to do in your journey, and there's something that I truly believe that even right now, after 2 years of general surgery, having tasted as to what it feels like to be a general surgeon in the US, or at least a trainee in the US, I am more than comfortable to say that this is what I want to do for the rest of my career. This is what I want to, this is where I want to train. This is what I want to do. And whatever setbacks you have, I will essentially try to show you that I have had all those setbacks. And despite those, I firmly believe that I'm going to be a general surgeon. So let's start off. So I started med school back in 2011. I initially wanted to go to Germany. I did my various things for Germany, the language examinations and everything. And I also got accepted to a school, but there were certain financial restrictions because of which I wasn't able to go to med school in Germany. Subsequently, when it came time for me, at that point in time, back in 2011, there wasn't a single entrance examination. There was like a state examination. There was a separate examination for AIMS and stuff like that. All right. So because I was essentially pissed that I couldn't go to Germany, I intentionally screwed up all my examinations in India. I would literally go in to the examination. I would draw patterns on the little circle boxes. I can also tell you that not all answers are weighed 25%, because I've done single answers. Like I've literally gone in, selected A for every single answer, and my score wasn't 25%. So I've done that as well. So obviously I screwed up all my examinations, and that potentially did bite me in my ass. But more importantly, despite being bitten in the ass, and when your colleagues are potentially going in and taking different examinations and being selected into different universities, there was a point in time wherein I even considered, instead of doing medicine, doing bachelor's in psychology. I was accepted at a certain college in Delhi University. I also considered doing bachelor's in biotechnology And again, I was accepted at a certain college. Furthermore, I was also given the potential option of just giving money and potentially buying a seat. All of which weren't necessarily my cup of tea. And when someone presented an idea of going to China and potentially doing my MBBS in China, I was, as a person who likes languages, cultures, I was very interested in that idea. And I landed up in China with a cumulative knowledge of just 2 words in Chinese, and they were the Chinese equivalent of hello. During my 5 years from 2011 to 2016, essentially many things happened, which first of all, I had a great teacher, one of my pharmacology teachers. He was the one who was kind of pushing the idea of potentially trying out for USMLE. By the time I was in the 3rd year of my medical school, that's when I realized that this is something that I should potentially consider. But again, I didn't necessarily have any mentors. I didn't necessarily have any people who were forcing it upon me or guiding me through the entire process, or telling me that, hey, this is what you need to do, this is what you should do, that I could have started potentially in my 3rd year, but I didn't. Anyway, I continued doing willy-nilly whatever I wanted to do. And, time passes by, and back in 2016, July 2016, I came back to India. At that point in time, I think people still need to take your FMGE to be licensed in India. Now, FMGE, especially as a person who's coming from a different country, and we saw that with the whole Ukraine situation as well in earlier on this year. International medical graduates, even for India, are seen in a different light. They're seen as people who potentially weren't able to crack the examination, first of all, true, or they weren't able to potentially get into a private medical college and pursue their education in India itself. For whatever reason, and this is, I guess, something that you can also basically draw similarities between the fact that there is a tendency between a nation, in this case, India, comparing that to another nation, the US, wherein there is a predilection towards preferring your own graduates as opposed to someone else who's coming from a different country. I took my FMG back in 2016, December, passed it in my first attempt. And in 2017, around March or April, started my internship. It was during this time, after I had passed my examination, after I was about to start my internship, that I essentially decided that, that I didn't necessarily want to work in India. And that was, I think, pretty much the little catalyst that I needed. I spoke to one of my FMG mentors, and he was the one who said that if you really want to prove yourself, if you really want to say that that you have arrived to the field, amongst my options were Germany, UK, and US. And I was equivocal to all 3 of them. My mentor said that the most difficult system to get into is the US system. And for me, that was, I think, the motivation that I needed. I was like, all right, fuck it, let's do it. Many people told me that it's going to be difficult, which it is. I will strongly agree with the fact that it's difficult. It is a long process. It's easier to potentially get into the medical system in the UK. It's potentially easier to get into the medical system in Germany as well, as a resident, as compared to the US. It's a longer process. It's a process that has multiple requirements, one of which is a financial requirement. which many people actually don't necessarily meet. And therefore, it does disqualify a lot of people from potentially appearing for this examinations, or is it at least a deterrent for so many people? Now, back in 2017, when I was during my internship, at that point in time, I decided that, hey, there's DAMS that gives its own coaching classes in India, in Delhi, and they had this USMLE program, and I signed up for it. It was at that point in time that I actually got a dedicated mentor in Dr. Mala Srinivasan, who's one of the coordinators for DAMS for USMLE, wherein she was able to guide me through the process, wherein she was the one who said that, hey, you're still doing your internship, you can potentially apply for electives, go for electives over there. She was the one who was able to essentially guide me through the process of applying for the various electives. Obviously, this was something that I had to pay for. Now, when you talk about all of this information, at that point in time, maybe 5 years ago, it wasn't as readily available as it is today. In today's world, there's so many people, there's so much information out there that is already available at baseline on YouTube. If you Google, as much as Google certain things, you can find a bunch of information about the USMLE, about how to prepare for your steps, how to apply for electives. And all of this information is readily available. So I think one of the most important things is that we should utilize all the resources that are available at our hand. And given that this is the age of social media, this is where everyone is able to connect through various platforms such as Facebook, LinkedIn, Instagram, for example. Therefore, I think it's a very good idea to potentially use everything in your armory. For me, when I was studying for step one, there were a few things that happened, and I think step one was probably one of the most difficult steps that I've taken, simply because of the fact that the way that our teaching is in India, I would also say in China, we don't necessarily have the same way of learning, or at least asking the questions. Back in 2017, FMG was a single, most of the questions were just single liners. I still remember that my first question on my FMG examination was, which of the following diseases has antibodies against GP2B3A? The options were your Glanzmann's thromboasthenia and what's the other one? I forget the other one already. But like the answer was Glanzmann's. So it's a single straightforward question. It's a single straightforward answer. Either you know it or you don't know it. And that was a big step wherein like I had to change the way my brain was trained, essentially, from answering a question which was either black and white to answering a question which was essentially a story, wherein you have to jump to a diagnosis by yourself, and from the diagnosis you have to jump to a specific answer that they're looking for. In my case, and I do think that step one is a hell of an examination. In my case, I was supposed to take the examination in March, and I took an NBME around 10 days before the examination. I scored really badly in like low 200s on the NBME, and I freaked out and postponed my examination to exactly 1 day before my flight to New York for my electives. I took the examination eventually. I don't necessarily feel very strongly about my scores, so I'll just disclose them. So I had a 232 on step one, which at that point in time was was a little bit above average. And on step 2 CK, I had a 226. CS was a pass. And that's how it is. So anyway, I reach New York. I start my first elective, which was neurosurgery. And immediately you could see the difference in the way a surgical ward was set up in India and in the US. And I think that elective essentially like opened up my eyes, and it essentially reinforced as to whatever I wanted to be. People were extremely nice. People were extremely helpful. And it was because of that, I'm going to just pick it up. All right. And it was because of that that I realized that even though, despite whatever my shitty scores, despite whatever my experiences of being an international medical graduate, even for India, despite all of that, it did reinforce the fact that this is what I wanted to do. I continued to, I did have internal medicine at that point in time as a backup. I ended up doing a total of 4 electives, which included 1 in neurosurgery at Mount Sinai Hospital in New York. I did 2 more electives at Mount Sinai Hospital up in New York, and 1 at FIU in general surgery at Hialeah Hospital in Miami. After this whole story, I took my CK. Like I said, I scored a 226 again. Again, I knew that I was stubborn and stupid enough to pursue this, and eventually applied for the match in 2020. So September of 2019, I applied for the match. I applied for internal medicine, and I applied for general surgery. At that point in time, I had a total of 5 interviews, including surgery and internal medicine. For my interviews in surgery, I only had prelim interviews. One was actually where Anudeep is currently, that is University of Minnesota. The other one was at University of Miami, which was a place where I was physically located and doing an observership in the Department of Cardiothoracic Surgery. Now, when you talk about, I think that was one of the most pivotal situations for me, wherein when I was submitting my rank order list, because when you talk about decisions, and I think that was one landmark decision, I decided to rank and take a chance with a prelim position, knowing full well that a prelim position would hand me a J1 visa. A prelim position is a contentious position in which I would have to apply for the match again. It would also mean that this is a position in which if I don't match, I would have to go back to India. Despite all of those considerations, I knew for a fact that my experiences in general surgery, in surgical departments in US were so profound that I wanted to pursue it. And I ranked all my prelims higher than categorical internal medicines. There was this one program that basically for internal medicine that basically said that they would be very glad if I were to match over there. When I sent them a sham letter of interest. But yeah, the program director was essentially like, "Oh, if you match at this program, it'll be great, blah, blah, blah." But I did rank all my prelims higher than my internal medicine categoricals, and lo and behold, I did match into my second choice, which was University of Miami, which was the place where I was doing my observership. Now, that was a pivotal moment, and I knew at that point in time that one of my mentors actually said this, that matching into a prelim, the easy part was over. That was till now the easy part, and that everything that I do, so on and so forth, would be would be what would determine the rest of the process. I started my residency. Obviously, there's multiple things that are different when you talk about hospital systems and when you talk about your clinical experiences as an elective, as opposed to being an actual resident. The good thing was that my program is largely international medical graduates friendly, and therefore there was a good support system that was available readily, especially with people that were prelims, and they were kind enough to help us out whenever we needed it. The funny thing was that one of the prelims from the previous year, when I was doing an observership, continued as a PGY2 prelim. So she was then subsequently my senior in the same program. My first year was amazing. It's a lot of hard work. It's a lot of long hours. You get to operate, and I think that was probably the best experience of my life, in the sense that I was able to operate. I built up relationships with people, my attendings. I think someone's unmuted. If they could kindly mute themselves. Thank you. So subsequently, I went ahead and I was able to, one of, I guess, the biggest achievement of my intern year was the fact that I got the equivalent of Intern of the Year award, which is, they call it Best Outstanding Resident, but essentially it's given to a person from the entire class. So amongst my entire batch, I was adjudged to be the Intern of the Year. I did apply for residency again. I did apply for categorical surgery again. Sadly enough, though, I did not get interviews this time around. And I think the biggest reason as to why I didn't get interviews, or the biggest reason as to why I didn't adequately use my resources, was the fact that while in the process of residency, I essentially skipped over one important part, wherein I couldn't necessarily find a mentor who would vouch for me. And this is something that, especially as a prelim, is very important, because prelim is almost like a gateway. It's a position in which it's a contentious position, obviously, because you only get a single year of residency, and then you have to prove yourself. And in my opinion, definitely it was worth it. In someone else's opinion, it may not be. As far as mentorship is concerned, I think within the 3 months of starting my residency and then subsequently applying for the match again is concerned, I guess I wasn't necessarily able to build up a relationship with the attendings to an extent wherein I could feel comfortable with asking them to call up on my behalf. But again, like I said, at the end, I did prove to them at the end of my first year that I was one of their best interns, and that's what they awarded me for. And subsequently, when they found out that I wasn't able to match into a surgical position, they offered me an option to stay at University of Miami for another year as a second-year prelim. So with the options that I had, I obviously took up that offer and continued my training at University of Miami. As a second year, the things are a little bit different, especially in surgical fields, wherein you are not necessarily seen as a senior, but you are like an advanced intern. That is, I think, the best description that I can give you. you, because of the 1 year of internship experience that you already have, you know the system in and out, wherein like you can do well for yourself and help the intern out. Conversely, depending on what level of comfort your senior has, they can still assign cases to you. They can still let you do a lot of procedures alone. And therefore, second year for me was an amazing experience. I think it was even better than my first year, because in my first year I was largely going to the operating room after I was finished with my floor duties and everything. As a second year, I was operating all the time. As draining, as taxing it was, I had 2 months of trauma, which is essentially 30-hour calls. So you start on day 1 at 6 a.m., you end on day 2 at 10 a.m. It's a horrendous schedule in terms of sleep, but it's a very rewarding experience, because you're always on your feet. You're always thinking, you don't know when a trauma is going to walk in. I've seen so much shit in the trauma bay, from like mangled up car accidents to people who were shot at point blank range, and people partying on a boat in Miami, because it's Miami. So that was one beautiful experience. And conversely, something that I really liked was also vascular surgery, which personally I didn't have much experience in before I started my residency. Vascular surgery, again, it has an integrated program, and it's a great field as well, wherein like you do a lot of endovascular stuff, you do a lot of open repairs as well. So that exposure during my second year, I think, has reinforced the same thing that I essentially knew, that I want to do surgery, and I will pursue it to whatever ends. Back in March of this year, when I was interviewing for second and third year general surgery categorical positions, I knew full well that if I weren't able to get a third year position or a second year categorical position, in that case, I would have to go back to India. And there were times wherein I did strongly consider changing my specialty. But I had friends and mentors who essentially didn't say that, no, don't change your specialty. They said that, understand that once you change your specialty, there's no way you're going to come back to this. Because that's the way that the system is, especially for surgical fields. Once you sway away from a surgical specialty, it's very difficult for you to come back into a surgical specialty. I considered emergency medicine. I considered even anesthesiology. And as a person who's worked with multiple emergency medicine physicians, especially in my own program, and also worked with physicians who are in anesthesiology, I knew that it was a potential option wherein like I could apply for the match again. I could potentially change to anesthesiology or emergency medicine. But again, I realized at the end of the day that what I want to do is surgery. And the most dreaded outcome of my entire journey, which was that after 2 years of general surgery, I could potentially go unmatched. Even though it sounds daunting, it isn't such a bad situation. It's not like, I'll give you my own example. So after I finished, so I interviewed at various places. I didn't necessarily get the third year position. I interviewed for research positions. And that's when I realized that ECFMG has a certain restriction on J1 visa of converting from J1 J1 clinical to a J1 research scholar. And because of that, I knew more or less that after I was done with my residency, with my second year of residency, that I'll have to come back to India. Now, obviously, for many people, this would be a bitter pill to swallow. This would be something that they'd be like, oh, you spent essentially 4 years of your life from 2018 till 2022 doing all of this, and yet you were not able to get into a surgical specialty. My answer to that is the biggest thing that I have now is that my application is very different from someone else's application. When I apply, I haven't applied for the match this year, but I'm no longer eligible to apply for the match for a first year general surgery position. With that said, when I apply for a second or a third year general surgery categorical position, I already have 2 years of general surgery experience under my belt. I already have people who are backing me from University of Miami, people that essentially still reach out to me. I recently had one of my attendings text me and she was like, hey, did you find something? And I told her that I didn't. But this is what happens when you work with people closely. And this is what happens when you are able to showcase that you're more than just a number, that you're more than just a score, that you are, in a sense, a person who's trying to achieve something. And if you work hard enough, and I think it was encapsulated by what Anudeep said as well. If you're stupid enough to dream and stubborn enough to chase it, you will eventually get it. As far as I'm concerned, I've been unemployed for the past 3 months, and I've had the time of my life. I think I definitely needed that break that I got, in the past 3 months. I traveled around with a few friends. I went to a couple of different countries and traveled around in the US. And now that I'm back in India, finally, I can focus on essentially trying to get back into the US. And I know for a fact that I'll go back. That is because I've interviewed at various research positions, and I was offered a couple of research positions already, but again, it was because of the J1 visa that I couldn't necessarily go back. So I'll just have to essentially wait it out, make sure that I'm making most of my time over here. And subsequently, I will eventually go back to US and pursue my training. So one of the biggest things that I would say from my entire journey, the most important thing from my entire journey would be that you need to be stubborn. You need to be relentless. You need to know what you want, and you need to pursue it to the end. There will be moments in your entire journey wherein things will not look good. There will be moments wherein you will feel weak. You will feel that this is something that you cannot do. And that's when you need a good support system. That's when you need someone to tell you that it's going to be okay. And as long as you have a good support system, you can figure it out. I know for a fact that there is nobody with a perfect application. There will always be someone. No one will come to you and be like, hey, I have 270s in my steps. I have 5 clinical electives. I don't know, I have a bunch of research publications and I'm applying for the match for the first time and I'm going to get it. Pristine applications exist, but they're very seldom. Pristine applications are kind of rare, to be honest. Everyone has something or the other in their journey that they will say that, hey, I could potentially improve on that. I could potentially improve on this. And that's what you have to realize. If there is something that you lack, if there's something that you don't necessarily have in your application, there are ways to make up. There's an analogy that I like to use, and that is of a cake and the gift wrap. So when you talk about your basic information, such as your step scores, your letters of recommendations, your US clinical experience, and subsequently also your research experience, that is the cake. That is what you're going to apply with your personal statement as well. That is what you're going to apply with. That is the crux of everything. Now, if you have additional stuff, such as if you have a home residency, if you have research experience in the US, all of that will essentially help. And that is essentially the icing on top, the cover that you are going to put on the cake, the gift wrap that you're going to give the cake to the person. Now, if, say, for example, you have a bad cake, make sure that the icing is good. Make sure that the gift wrap is good. Make sure that it looks presentable. And I'm not saying that it's going to be easy, but at the end of the day, somehow it'll work out. There are multiple people in multiple specialties to whom someone said, hey, this can't be done. Hey, no one has ever done it. Hey, this is not possible. And yet it was probably because of the sheer stupidity or the stubbornness that they were able to get into it. But there are examples of people who make it. In my own program, we had 5 international medical graduates. 2 of them were from India. Categoricals. I'm strictly talking about the categoricals. So 2 of the categoricals from my program are from it. Well, one of them graduated. 2 of the programs, 2 of the people were from India, graduated as general surgeons already. One of them is doing colorectal surgery fellowship. There were other 3 people from other parts of the world. One was from Turkey. He's doing breast fellowship. One was from where is he from? From Somalia, and he's doing trauma and critical care at University of Miami. So there are multitude of examples as to the fact that it can be done. You just have to be stubborn enough to pursue it. And I think that's all I want to say. I'll gladly take any questions if people have questions.
First of all, Dr. Ishit, that was a very eloquent, very candid speech that you gave. And I must say that you come across as a very persistent person who is not afraid of persevering and is not afraid to take risks. And as you said, keep going on. That is, I believe, the energy that kept you going. So I would like to begin with the questions. The first of all is, as you said, red flags. You had lots of red flags in your application. I'm curious to know how you addressed it in your personal statement.
So what many people think as straight out red flags aren't necessarily big red flags, and unless you have something like as a failed step score or failed step, or unless you have something that is completely lacking, only in that respect, I would say, you have to address your your failures. Your personal statement, and this is what I tell everyone that has ever asked me about a personal statement, is that your personal statement is a blank sheet of paper on which you can essentially direct the way your application needs to be looked at. In my case, my personal statement is about soccer. I play soccer. Even to this day, I play soccer, and I've played soccer throughout my life. I essentially compared how soccer, or the setup of a soccer match, is similar to what it feels like to be in an operating room, wherein you're a part of a team, wherein you are the one responsible for the team. Your actions are directly responsible for something. In a soccer match, it's a goal or winning. In the operating room, it is the person in front of you. So as far as drawbacks, or as far as red flags are concerned, until unless it is something that is completely lacking. So say, for example, if you've failed a step, in that case, I would say, yes, you should address that in your personal statement. Until unless it is something, if it's something manageable, if it's like a step score which wasn't necessarily great, again, I wouldn't necessarily shed light onto it until and unless you feel very strongly. You have to make sure that you endorse yourself. Your personal statement is basically an advertisement. It's an advertisement in which you can write everything or anything about yourself. And from there on, whatever they want to look at, they will still look at. As far as average scores are concerned, average scores aren't a drawback, aren't a red flag. As far as visa is concerned, visa as an IMG is a red flag for every single IMG. You are no special IMG that specifically you require a visa. If you have a gap, especially if you have a gap of greater than 3 years, that would be something that I would essentially address, especially if you haven't done something clinical, because that is something that they would look at and they would be like, oh, you have a huge gap as to why you have that. And that is something that you want to address in your personal statement. Conversely, anything less than 3 years, I don't necessarily feel very strongly about addressing that either. So in your personal statement, make sure that you're endorsing yourself, you're advertising yourself, and do it in the best way possible so that people who read your personal statement know as to what background or what situation you're coming from, and can give your entire application package the attention and the care that it deserves.
Thank you for sharing your thoughts, Dr. Ishit. There's a question about an attendee. Like, he says that he has already trained in surgery IMG from India. He has average scores. His year of graduation is 10 years old, and recently he did transplant fellowship in the US. How can he match into the general surgery programs? What can he do to improve his application presentable?
So for that person who's, he already knows how the system works. If you've done a transplant fellowship, that means you already have 2 years of experience, because abdominal transplant is 2 years. There are actually states wherein you can actually even practice after just doing fellowship. So in the state of Florida, you can get a limited license to practice at a specific institution if they offer you an attending's position. Conversely, you can obviously, like many people do, want to do their own residency before they continue as an attending. That is because it gives you the ability or the flexibility to change potential places of work if you ever want to do that. Now, As a transplant fellow, I would say you definitely have people backing you, or you should have people backing you after 2 years of fellowship. And I think the best way of going about getting into residency would be to ask the people that you've worked with to endorse your candidacy at various programs. Once you do a fellowship, they know that you're a known entity, and that is something you might even have to potentially consider a prelim position and then go on from there. But again, those are the various options. I don't think there's a secret to it, but I think publications and contacts are going to be your best bet.
Right, because there was just a question in chat box that because there's about surgery, they say that it is so competitive that you have to have significant research under your belt. So what if an applicant does not have that? Because after all, most of us are medical students. Some of us do not get enough opportunities. What about applying to surgery with little to no research experience?
As far as I'm concerned, when I applied the first time, I only had 2 publications. The first one was from GB Pant Hospital, where I was working in Delhi, and the other one was with one of the prelims while I was doing an observership at University of Miami. So as far as research is concerned, it is becoming more and more, and essentially like a unstated requirement. Again, like I said, when I gave you the analogy of the cake and the gift wrap and the icing, your research is essentially the icing and the gift wrap. If you think that there are parts of your application that aren't necessarily strong enough that would be able to get you a position as a general surgery categorical, then you should consider doing a research year. You should consider doing a year of surgical research so that you can publish something. I know of people who do that. I know of people who even do 2 years of dedicated research and then apply for general surgery residency. As far as any competitive specialty is concerned today, it is becoming more and more likely that you will require some sort of research. You will require some sort of background in research. And therefore, that is what they expect your application to be as well. For anyone who asks as to how many publications or what kind of research you need to have, I'd redirect you to go to the NRMP website. They have something called the match data, where like they have charting outcomes, and it gives you the exact number of publications, scores, and various other experiences that an average applicant to that specialty has, and an average applicant that was accepted to that specialty has. And you can check all of that information out on NRMP's website.
Thank you for sharing that, Dr. Ishit. Another question along the same line. Now, general surgery is a very hands-on specialty, right? So can an observership done for general surgery translate into a strong LOR, or is it only electives that is advisable and works?
So in as far as electives, observerships, sub-Is, and externships are concerned, I think in order of priority, it goes from sub-I to elective to an externship to an observership. Now, answering the actual question, which one is ideal, or what if you don't have electives? So if you have the option of getting electives or sub-Is, definitely 100% go for those. Yes, it is a hands-on specialty. Yes, this is something that, ideally you wanna be involved in. because just standing and observing a surgery can sometimes be a little bit boring. Conversely, just standing and not talking to a patient or not examining the patient or not, I don't know, simple thing. If a patient presents with a hernia and all you can do is just look at it from 6 feet, you might as well not, you will probably not even get your money's worth. With that said, you only, if the options of elective or sub-I exist, definitely try to get those. If the option is no longer there, wherein like you're already graduated, wherein you're already beyond the timeline wherein you can apply for an elective, I guess the best thing would be to do an observership. And even during observerships, there are certain things that I expect my medical students to do. And that is, I always expect my medical students to show up on time. If I am rounding at 6 a.m. and my medical student is showing up at 6:30 or 7, that is unacceptable to me. Either A, they should say that they're not interested, or B, be present at the time that they need to be. Conversely, I would say that being present is a huge thing. Being knowledgeable in the sense that when you see certain cases, it is not expected out of you to know every single thing, every single detail about every single surgery or procedure or pathology. But being proactive in the sense that you are informing yourself, you're showing interest, all of these things matter, and all of these things can potentially help you stand out, even in an observership. If, say, for example, if someday you're talking to an attending about a specific complication of a specific case, maybe you should look up when you go back home or when you have some downtime as to how many patients actually have that kind of a complication. Maybe see as to how many publications are there about such complications, and maybe even talk to your resident or fellow or your attending if you can potentially even publish that, if that is something that you can write up as a case report and potentially publish. So these are the various ways I would say, even as an observer, you can stand out. Like I said, when I was doing my observership, I spoke to my resident on in the Department of Cardiothoracic Surgery, and I was eventually able to publish an article with him, even though I was just an observer. Those are the things that you can potentially do to stand out.
Thank you for sharing that, Dr. Ishit. Another question is, does working as a surgical assistant help in gaining the experience? Surgical assistant.
It can, yes, but there are better ways of addressing your time. Unless money is a huge concern, I think there are better ways in which you can address this kind of a thing. A surgical assistant at the end of the day is just a surgical assistant. Yes, obviously, the time that you spend in the operating room is going to count towards you. It's going to count as something that is beneficial. You'll already know what certain procedures that you've commonly seen are like, as to how the procedures go ahead. But again, as a first-year resident, that is not what they're looking for. They're not looking for someone who can be a good surgical assistant. They're looking for someone who can be a good resident. Now, for you to be a good resident, they want to see your research acumen. They want to see you performing well on your various examinations. They want to see that you can prove to them that, hey, this person is actually able to do what is expected out of a surgery resident. And as far as job description of a surgery resident is concerned, it's not to be a surgical assistant.
Thank you for sharing that, Dr. Ishit. Another question is, some of our audience do not know the difference between categorical, preliminary, and transitional year. If you could address that. And there's also specifically, they have asked if can any of these be done on H-1B visa?
As far as visa is concerned, straight up, it really depends on the program that you're applying to. Can it be done? Yes. Will the hospital sponsor it? That really depends on where you get accepted, where you match, and various things that are beyond your control. Now getting back to as to what categorical, prelim, and transitional means. Transitional is essentially a one-year contract, but it is an overview in every single specialty. So if you do a transitional year, it is much like doing an internship in India, wherein you didn't know as to what specialty you wanted to apply to. So you want to have more experience in essentially every single specialty. So they'll give you a few months of internal medicine, a few months of surgery, a few months of radiology, a few months of this, a few months of that. And then you can potentially decide as to what you want to apply to and reapply again. Most of the people that I know who have done transitional years are American medical graduates who did not know as to what they wanted. As far as prelim year is concerned, prelim year is offered in surgery. So you have PGY1 surgery, you have PGY2 surgery. A prelim year is also offered in internal medicine, which is only PGY1 internal medicine prelim. A prelim year is just a single year contract in that specific specialty. For many specialties, such as diagnostic radiology, such as what else? I'm blanking on the names of specialties, but a prelim year essentially is a first year of residency that you need to apply or to get accepted or to continue your training in a different specialty. So say, for example, if you're interested in diagnostic radiology, you can apply for a PGY1 prelim in surgery or a PGY1 prelim in internal medicine, and also apply for diagnostic radiology, which is an advanced position. If you're interested in, say, for example, PMNR, which is physical medicine and rehabilitation, again, the same thing. You would apply to prelim 1 surgery or prelim 1 IM, and then subsequently match into an advanced position in PMNR. Anesthesiology also requires you to do a prelim year. Certain specialties, certain advanced specialties are designed in such a way that they require you to have a first year prelim. Whereas in my case, I was in general surgery prelim with an intention of just applying for general surgery. It is a one-year contract wherein you have the same responsibilities as a PGY1 categorical general surgery, and you're expected to carry them out as a resident, obviously, and subsequently you can apply again for the match, or you can continue as a second-year prelim, which is what happened in my case. A categorical position, a 5-year position. You enter that specialty, and you will end as that specialist. Yeah.
I hope that answers the question whoever asked that. We have another question from the audience. Someone who says that because you did an elective for neurosurgery, at what time you particularly knew that it's general surgery for you and not neurosurgery? And obviously that's subjective, but do you think that there is an it point of time when you feel that you have to be in general surgery, not neuro or CTS or orthopedic and plastics, vice versa?
So for me, the reason why I knew that I didn't want to do neurosurgery was because there was a specific case, a specific patient that had a bad outcome, and I was like, nope, that's not it. So essentially, it was a patient that had I'm trying to remember. It was a 50-something-year-old female that presented with a left cerebral mass, underwent a left hemicranie, had a resection, and within, after the surgery was over, within the next 8 hours, developed a stroke, had right-sided hemiparesis, and stayed in the hospital. So my elective was 4 weeks. She was one of the first few cases that I saw, like within the first week. She was taken back into the operating room again when she had a hemorrhagic stroke. So when she was taken back into the operating room for clipping, I was there for that case as well, and essentially looking at her from the absolutely, the outcome essentially for me was bad, and therefore it deterred me from applying for neurosurgery. The other thing was that my application was weak for neurosurgery. That was another thing. Neurosurgery is a specialty that, like Anudeep mentioned, it's a specialty that requires you to have a very geared application towards neurosurgery. My application wasn't geared towards neurosurgery. So therefore I knew that I didn't want to apply for neurosurgery.
Okay, great. Those are pretty great pointers. Someone says, what are the scopes for CTS, i.e. cardiothoracic surgery, and what are your suggestions regarding this?
So scopes as in what is the potential future of cardiothoracic surgery, or
I think that's what the person's maybe trying to say, that what kind of advancements or how can someone push themselves into learning new skills through CTS, probably. If I'm incorrect, the persons can explain it more, but I think that's what they're trying to say.
So as far as cardiothoracic surgery is concerned, there are two ways of getting into cardiothoracic surgery. One is the general surgery pathway, which is 5 years of general surgery, and then you subsequently apply for a CT surgery fellowship. Or there is an integrated I6 pathway, which is a cardiothoracic surgery integrated program wherein you start off with cardiothoracic surgery right off the bat. They'll teach you a little bit of general surgery, but then you subsequently specialize in cardiothoracic. There are certain hospitals, such as Washington University in St. Louis, that offer the accelerated pathway, which is essentially still general surgery plus cardiothoracic surgery fellowship. But in the 5th year of your general surgery residency, you can do 3 to 4 electives, which is 3 to 4 months of cardiothoracic surgery, and it sets you up essentially for your cardiothoracic fellowship. Now, as far as the future of cardiothoracic surgery is concerned, it's not going anywhere. There are obviously multiple things that have taken over from interventional, specifically interventional cardiology has taken over a lot of things with the basically PCI coming in, with the other things such as TAVR and minimally invasive valve replacements coming in. So there are multitude of new technologies that are coming in that have been taken over by essentially interventional cardiology. But as a person who's interested in cardiovascular surgery, I can tell you that cardiothoracic surgery is not going anywhere, simply because of the fact that as long as there are cardiologists, they're bound to make a mistake. And as long as there's a mistake, they need a cardiothoracic surgeon to open up the chest.
Sounds good. So another question is that what are the best ways to showcase our clinical knowledge and skills in a surgical setting?
Okay. As long as you sound interested, I guess. I think the best way to showcase your knowledge or your interest is by making sure that you're asking the appropriate questions, and you're asking you're interested in as to whatever the pathology is there in front of you. So say, for example, if you're looking at a patient that has, I'll talk about just general surgery questions. So say, for example, if a patient has some sort of cholelithiasis as opposed to choledocholitis, as opposed to, say, I don't know, Budd-Chiari syndrome or something like that. Knowing as to which one is which, as to how to differentiate the ones, and more importantly, when you see one, understanding as to what the diagnostic steps are, as to what the treatment steps are. Those are the things that you should know, and that's how you showcase your knowledge and your interest. If you are the kind of person who I don't know, for whatever reason, is just disinterested in things, that is something that we as residents can pick up. If you're completely just absent or not asking any kind of questions, we know that you're probably not interested. So just as long as first you're present, and B, you're actively participating in whatever is going on in front of you, you should be able to showcase as to whatever your knowledge is, and as long as you're asking the appropriate questions.
Great.
Dr. Ishit, thank you for sharing your thoughts. One question that I think IMGs usually face is problem they face is that networking once they are in the US system. Networking plays a huge role once you are in the US healthcare system, be it entering into residency or applying for fellowship. And as IMGs, we are a little hesitant compared to an AMG who is very outspoken. So how do we go about that? What is your what are your suggestions for networking? How to go about it?
So one big thing that people don't necessarily realize is that people, when they're interviewing for a residency position, they know that you're going to be there for 5 years, potentially. In certain cases, 7 years, because you might have to do 5 years of residency plus 2 years of research. So they know that you're going to be there for a while. They want to make sure that you're someone who is personable, someone that they can talk to, someone that has the basic mannerism of a human being. Now, because of whatever reason, I still to this day get messages on Instagram in which people outright ask me questions, almost expecting, like, hey, tell me the answer for this. This is my question, tell me. That is not a way that you ask a question to anyone. If I were to approach, it's almost like approaching a girl. If I were to, I was potentially talking to a girl or with the potential intention of flirting with her, I wouldn't be like, hey, give me your number. Like, just basic courtesy is something that goes a long way. Being polite is something that, again, goes a very long way. Just being someone who's more eloquent in presentation, in speech, that is something that also goes a long way. Now, as far as people and as to how to approach people is concerned, you don't necessarily have to have the speaking skills of, I don't know, Barack Obama to be able to communicate something. There are people who don't have such great speaking skills, but still certain topics can bring you closer together. So say, for example, in my case, I can give you an example. I interviewed for a third-year position, and while I was talking to the program director, he was someone who was interested in soccer. And because my entire personal statement was about soccer, we essentially, during the entire conversation, talked about soccer. I talked about the team that I like. I asked him the teams that he likes, and stuff like that. So again, at the end of the day, they're trying to make a human connection with you. They're trying to make sure that you're someone who's personable, someone that they would like to work with, someone they would like to talk to. And those are the things that are essentially the most important things. So if you have a common topic, if you have something that you share with that other person, those are the things that you would like to bring up. As far as networking is concerned, it's a similar concept. You want to make sure that you come across as someone that they would like to help. In my case, there was this one attending that towards the end of my second year, she asked me, hey, when are you going to start? Because her rotation was a third year rotation. And she essentially asked me, hey, when are you going to be on this specific service? And I was like, I'm sadly not going to be on that service because I'm a second year prelim and I don't have a third year position. So she was essentially almost shocked. She was like, oh, you're a great resident. Why don't you already have a third year position and blah, blah, blah. And subsequently, when I started having a conversation with her, she actually even offered at that point in time that if I needed a letter of recommendation or if I needed someone to reach out on my behalf, she would gladly do it. So first of all, let your work do the talking. If it is someone that you're working with, if it is not someone that you're working with, be courteous, be polite, and try to find a common subject that you can talk about. That common subject doesn't necessarily have to be football. That doesn't necessarily have to be something academic either. It could be anything that you potentially share with that person. Most likely thing that you might share is something academic related to a patient, something that you might be interested in.
Great. Thank you, Ishit. So we have another question, which is part A and part B. I'm going to break them down into two parts. So A, what, I think we all are aware. However, what's your take on the difference between research positions in US versus India? Because I think, every place has its own pros and cons. India being a smaller country, the positions are less, but people who work are less again, so the ratio balances out. And in US, the same ratio is higher, which means positions are more, people are more. So what is your take on that? And point B, can you share some interview questions that people ask very specifically in a surgery match and not in any other specialty? Some of the very specific surgery, general surgery interview questions.
All right. So as far as research is concerned, the biggest drawback of doing research in India, at least in my opinion, is there is a lot of data manipulation. That I have actually seen firsthand when I was doing my research at GB Pant, and because of that, we had to even exclude a certain number of patients that on whom data was collected. Data manipulation at baseline does exist in India, and therefore, many a times when you publish good research from India in international journals, it is still disregarded simply because of the general acceptance that it is something that has bias in it. Obviously, there are institutions such as ICMR. There are premier institutions in India such as AIMS, Maulana Azad, which try to do good research, but again, that possibility of bias does exist. I'm not saying that possibility of bias does not exist in the US. I'm just saying that this is one of the biggest drawbacks that is, I feel, very inherent to the Indian scenario. So the problem is that when you talk about research in the US, obviously it's a more competitive pool because there are more people applying for this. But the crux of the matter is that the research that is done in the US, first of all, it's easier for you to publish, even if you're doing a simple case report under an attending who's already established in the US. It's probably easier for you to publish a case report in the US as opposed to somewhere else. Conversely, as far as even as far as even letters and contacts are concerned, your research experience is also potentially something that can bring you a letter of recommendation. It is also potentially something that can bring you various contacts. Now, if you are able to use your resources correctly, it is probably more beneficial for you to do research in the US, publish in the US, get a letter from a known entity in the US, as opposed to doing it from somewhere else. Now, at the end of the day, if the possibility completely does not exist, something is better than nothing, and potentially, yes, do something in India as opposed to do completely nothing. But if you have the option of potentially going to the US or even going to Canada or European countries, I think that is a better idea than publishing in India. Talking about interview questions, I think largely interviews are not academic. I've only had one interview ever in which someone asked me a clinical question. Otherwise, it's largely questions about largely open-ended questions such as, tell me about yourself, what are your interests, what are your strengths, what are your weaknesses, the basic bread and butter questions that are there. The other things that are also asked are behavioral questions. Now, behavioral questions are the ones in which they would ask you questions such as, something that I was asked was, you're in the ICU alone at night, managing the surgical ICU or the trauma ICU. And when you are in such a situation and a patient is crashing, what would you do? What would be your order of priority? They essentially want to see as to what your thought process is, as to what you are going to do if such a situation arose. Another question that I was asked was you're managing a patient that is post-op day 0 from THE, which is a transhiatal esophagectomy. And after that procedure, the patient is suddenly having respiratory distress, is tachypneic, tachycardic, and you, as the person who's there overnight, suspect a PE. You call up your senior, and your senior says that I was in that surgery.
So sorry, continue.
Yeah, so your senior, you call up your senior says you were in that the senior was in that surgery. They finished the incision and everything. They were the one who did the anastomosis, and they are perfectly sure that it is not a PE, it is not an anastomotic leak, whatever. Because there is a baseline disagreement between you and your senior, what would you do? How would you resolve this situation? And how would you go about this? So again, what they want to know is not your management of a patient that is decompensating. They would want to know as to what your problem solving skills are, as to what you think is right or wrong for the patient, and as to how you would go ahead about it. So those are the kind of behavioral questions that they ask. As far as the only clinical question that I've been asked was a patient presents to you with abdominal pain that started about 4 hours ago. They essentially wanted me to run the entire scenario, essentially almost like a mock oral for the boards.
Great. Thanks, Ishit. Another question says that when advancing to specialties, again, like neurosurgery, ortho, CTS, etc., what things the applicant should keep in mind when building a curriculum vitae? So,
when you're applying for advanced positions or more competitive specialties, they do look at multiple things. Especially your research acumen. You should, in general, be a competitive candidate. I think that was already established by Anudeep when he was talking about neurosurgery. Neurosurgery is an absurdly competitive specialty. You should be a competitive candidate. With that said, there are things that you can do to improve your entire application. One is research. Good research in any specialty is going to be helpful. Ideally, you want your research to be in that specific specialty. You need to find good mentors. Mentorship helps. Mentors can essentially make you or break you. If there's someone who's batting for you, if there's someone who's vouching for you, that person can potentially endorse your candidacy to a specific program. And it could be something that essentially makes your entire interview. I interviewed at a place where the chair of the Department of Surgery specifically asked about 3 people. One was the chair of my Department of Surgery, the other one was my program director, and the third one was one of the attendings that I had never worked with. So as far as the chair and the PD are concerned, I told him that these are people that already know me, and I even asked my PD to reach out to the chair of that Department of Surgery. So mentors can make or break you. And finally, if you do take up a position as a prelim, you can still make sure that you're still endorsing yourself as a candidate to that specific specialty. In my case, for example, something that I was interested in was vascular surgery. So whenever I had the chance, I would scrub into vascular surgery cases as a PGY1. As a PGY1 prelim, I would still go into the vascular cases and try to help out in the vascular cases. I would make sure that I was always on top of my patients when I was doing my vascular surgery rotations. Not that I wasn't on top of my patients while I wasn't, but taking extra care, I guess, going the extra mile. So those are the things that you can potentially do. Publications, even while you're in your residency, can also help. So make sure you're making your contacts while you're doing your prelim. Make sure that you're publishing with the people that you're potentially going to work with. And all of these things can potentially help you in matching into a hyper-competitive field such as cardiothoracic or neurosurgery or ortho. I know of people who have done prelim years. Well, Anudeep was someone who's done a prelim and then matched into neurosurgery. I know someone who's done prelim, gen surg, and then subsequently matched into ortho. I also know someone who did cardiothoracic surgery research for 3 years and then matched into a cardiothoracic surgery I6 program.
Thank you, Dr. Ishit, for sharing your thoughts. With this, we have arrived at the end of our session. Could you please share your contacts and any way our listeners could reach out to you if they need further advice?
So, as far as Instagram is concerned, and how Zishan already mentioned, Instagram would probably be the best way of reaching out to me. I may or may not necessarily reply immediately, but I do tend to have days wherein I just sit down and start replying to the bunch of messages that I get. So reach out to me on Instagram. It's my last name, first name, 29. So it's Chauhan Ishit 29 on Instagram.
Thank you so much, Dr. Ishit. With this, we
Thank you.
conclude the session. Thank you.
Thank you.